And then we put it on my channel. Yay! I forgot what I was talking about. I got nervous. I get camera. No, we were talking about the hypoplastic. Say right hard. What happens in a hypoplastic? Hypo is what?
It's not formable.
Is not developed entirely, right? So therefore, we're going to have a small, tiny ventricle, right? So how is that volume going to affect the rest of the heart? If it's a tiny, it's not getting blood, right? So that's when, how will that pressure on the right heart, on the right ventricle will look like? What is the normal pressure on the right ventricle? About 25. So what do you think it's going to look like?
It's going to increase because it's one.
So with that, we need to know what a normal is, so we know what we recognize what abnormal. So I'm going to give you some pressure recognition for anomalies. Very simple. They're very simple. I mean, there should be something like the question I just made you, and it should be on a graph, or it could be with information. You know, you've been doing case studies, right? Yes. So the purpose is that you start putting all the elements together and start recognizing when there's a problem, right? But to know when there's a problem, we need to know what normal is. So you're going to have about 4 or 5 of those recognizing the pressure waves or saturations or anything like that. We also need to know on congenital defects, the cyanotic, which ones are cyanotic, which ones are acyanotic, or I guess just the cyanotic are labeled. So what is a cyanotic defect? Not enough oxygen to the system.
Oh.
To the system, right? Because that's when you can see it on the irrigation. So I want you to think about if you were to dissect me in, like a CAT scan, it's like, so if you were to put me on a flat surface, when you do all the cuts, the heart is responsible to irrigate all this tissue. And we're going to put it in a height and weight. So it's going to be area that the heart needs to irrigate. Yeah. So if the heart doesn't have enough fluid, right, enough volume, it's like an irrigation system, right? It's going to irrigate certain areas, and then some areas are not going to get that. So that's where we see the pale colors, right? The bluish type of color, because there's no enough irrigation to this surface. Yeah, we're going to talk about that. So you're going to have to see those examples. For the congenital defects, the ones that you made the assignments on, we might need to know what are some of the diagnostic tools, right? What would be a diagnostic tool for a defect? An echo? Yeah. Physical exam, right? Symptoms, we're going to go by the symptoms first, right? Why do the patients go? Just I can't breathe, I get tired. Obviously, if it's a baby, we're going to notice right away, but it will be as soon as the baby is born. Say we don't have any information on this patient and baby's born. We immediately assess the baby for oxygenation. So is the Apgar system. So we check and we give the baby a grade per se. So we're going to notice right away baby's not the oxygenation. Baby gets pulse ox, temperature, and weight, color. So we assess right away. So I think it's like 6 topics that we check as baby's born. Say we don't have any information on the baby. And then oxygenation is going to be the first one. So NIC is going to be the first one to be called in, and then we take it from there. So that will be symptoms, CAT, echo, X-ray, CAT lab, no CAT scan, but it can also be, and in the CAT lab, right hearts for structural hearts. Some of the defects that we saw, the assignments that you made, the trilogy of a lot, it's going to be there, right? You need to know the defects and some of the repairs, right? Remember we talked yesterday about the What do we do when the right ventricle is so tiny, tiny? One of the things is like we're gonna kind of slice the ventricle and put a patch on it to kind of like enlarge it. And it's a patch, right? What else are we gonna do on tetralogy of Fallot? What are the defects? BSD. So what can we do for the BSD? Septal defect, more likely an Platzer, but this is a brand name, so it could be any other name, right? And Platzer. What is the second defect? Overriding of the aorta. What does that mean?
So you have blood coming in from the ventricle of the aorta.
So what can we do there? One repair is going to be septal defect, is going to be there. And then the other one will be probably a septation, right? Because we only have one branch. The truncus arteriosus doesn't develop into two. And then we need to create that septation. Remember, that was part of what we saw yesterday. So that will be another, and it's a series of. So it might be, the question might be related to that. What is the repair for this or that? Kind of like what we saw in the exercise yesterday. What else? The transposition of the greater vessels. That will be a what? Arterial switch. So I want you to be able to identify like images. That's part of the assignments that you did, like the description, the images and stuff, right? So to put it together. Let me see. We have in episode 1, week 1, we have the fetal circulation, 4 videos. So you might want to go back and see those.
The development of the heart.
The 4 videos, one is the heart embryo animation, the cardiac development, fetal circulation before birth, and then the baby circulation right after birth. So those are from module 1.
Are you doing also chapter 1 for the midterm, like knowing the phases 1, 2, 3, 4?
No. We're going to talk about that plenty of times going forward.
Thank God.
But because one is just the action potential and things like that. Yeah, not right now. It's a topic that we need to talk about, but not now. Let me see what else. Hang on. The size of the ventricle or stenosis of the pulmonary artery, right? So we have stenosis. Which defect has pulmonary stenosis? Tetralogy of Fallot, right? So it's going to reflect back on the already small ventricle. So you bet we're going to have the pressure is going to be, right? So if we see a pressure wave that is over the 25, right? So what does it indicate? And then you're going to have some possible answers. And more likely is going to be related to the defects. There's a lot of reasons we can have a increased pressure on the right ventricle, but right now we're talking about congenital defects. Does that make sense? Because it could be pulmonary embolism, for what I know, right?
What you're saying is, like, when you're looking at it, these are the
Congenital defects, not about anything else, just congenital defects, so we can recognize that. Because next time that you see it when you're in clinicals, you're going to see increased pressure on the right ventricle, and then you're going to start questioning, like, why, right? So we are there to do scrub, to do monitor, to do circulation, but we need to know where we there. What happens to the patient? Many times we go to clinicals and I ask the student, what does the patient have? Oh, I don't know. You're monitoring. You should know. And we don't know. So then that puts A and B together, right? Like, okay, we have this hypertension because yada, yada, right? So that makes you act or make notes or whatever the case might be. So you're going to have images to represent pathologies. It might not be the same images that you've seen before, but if you can recognize, remember that we saw yesterday, for example, the hypoplastic, where the aorta is like super, super tiny. And then we have to create a shunt, right? So more likely it's not going to be the image that you've seen before, because that's not how the heart is, right? So it might be another image representing that. The procedures, we talk about the matching exercise that we did yesterday, the procedures, more or less need to know what they are. The Fontan, the Norwood, the Rashkin, the atrial switch, not the atrial, see, I said it again. Atrial is not atrial, arterial switch. Now it's gonna stay in my heart like this. The shunt that we're talking about, the Blalock. Pretty much everybody got right the prostaglandin and the use. Pretty much everybody got it. Okay, you did the exercise that you did about the pathologies and the symptoms, diagnosis, treatment, yada yada. So you might have a question related to all those answers: symptom, diagnostic, and treatment. So you might select multiple. It's a multiple selection. Multiple choice, multiple answer, huh?
So if you have juxtaposition, what would we see?
So for example, if we do, say a patient, easier, septal defect. How do we diagnose that? What is the symptom?
Symptoms can be
Blue, cyanotic, right? So patient is cyanotic. So you might have on the list, patient is cyanotic, which applies to a lot of the defects, right? But then it says also, right heart study, perform or confirming shunt, left to right shunt. Okay, then it's more specific, right? Now it's not because the ventricle is small or large. Now it's because we have a defect, right? So now it's guiding me to what it is. And then the last one might be we utilize a closure device, a septal closure device. So they put them all together. Yeah, so it might be 2 answers, 3 answers, all of the answers. Does that make sense? So we're starting to put all this together. It's very simple. It's not nothing like Mr. Ochoa's assignments, because I was looking at him yesterday. Nothing like that. So it's just like, ding, very condensed. We have to be more efficient than, right? So it's not the amount really of work. Okay, you're gonna need to know, we talk about that, the normal pressures on the chambers.
Are their pressures still the same if they're larger, smaller?
We're talking about normal pressures. And remember, it's a gap, right? It's like the 120/80 that doesn't really exist. I actually have never seen anybody with 120/80. It doesn't exist, right? But it's like, give or take, somewhere in there. So you're also gonna have matching exercises to match the defects, the congenital defects, and also the repairs. In a very, very similar fashion that we did yesterday. Right? Identify what is happening where. What's that? Dr. Lawson, good morning.
Hi, good morning.
How are you? Welcome. Welcome. This is Dr. Lawson, our president. She's the president. Oh. Like, oh. If she's around, you're like, oh. Stay straight. Stay put.
Checks.
Yes. She's our biggest donor for to support for scholarships. She's the biggest donor. I think it's like $30,000, something like that, every year. Every year. So good job. So some of you get, because I know I got it at some point, like I was gonna pay my accountant, like you had like $1,000 scholarship, blah, blah, blah. I was like, okay, I'll take it. But so it's from this fund. And I guess they just select, randomly, because I didn't apply or anything, but of course things were different, right? Do you have any questions?
How many questions are on there?
No, I removed that. What happens is you can transfer information from other courses. The last course that we taught was a condensed course. So yours is 8 weeks. That course was 4 weeks. So they did a lot. For midterm, I wanted to die. It was almost like a final. So I was like, pobrecitos. But it was like that. These students, they were from Houston. They are students that already have an associate's degree. And they can do, we partner with Methodist system to train this already associate degree. They already work in the facility. Respiratory technician or respiratory therapist, radiologist. I had an EMT, and what else? Something else. So they selected, because there was a shortage. There's no school in Houston. So they needed, to train people like ASAP. So we trained these people in 22 weeks, I think. So their labs were 8 hours. 8 hours. So they came for a whole 2 days in a row. So it was Monday and Tuesday, whatever the days, back to back lab. So what you guys were learning in one day they learned pretty much scrubbing the whole thing. It was a lot. So they had this condensed version of the test because it was like that. So I was like, oh yeah. So, but don't worry, I have the questions set for the next test. So besides that, questions related to the topics. Huh? No, don't panic. I think it went down to like 50 or something like that. But then remember, it has sub-questions. So, yes.
So yesterday, it was mentioned that the tetralogy of the law had been Norman, Glenn, and Tom. I don't know his last
The
name.
tossing.
I thought that was for just HR, HS, HLS.
Well, if they do have, some of the pathologies are the same, right? Because what other condition has the truncus arteriosus?
Truncus arteriosus.
Well, truncus itself, that's what I meant. So by itself, and then we have to perform that septal, right? That same thing that we perform on that one. So a lot of this, but I'm not gonna confuse you. That it's gonna be very specific, to that. So it's not gonna be like, guess which one of the 4, because it might be all 4, right? That we use. The septal defects. Any septal defect qualifies for 5 for the same device, right? So it's not going to be tricky or anything like that. It's going to be very. No, that comes in the next semester. Victor, you like math? Math? But then if you like math, it's going to be probably your environment, yeah. Because if you have that math brain, it's like it makes sense, Yes. Just a reminder, we have to pass this not this midterm. Well, actually, I think you have to pass the midterms too. But there's no reason not to pass, right? That's what we're going over. So any other question on the material?
Can you go over the prostaglandin,
And the effect?
Yes.
So what it is for?
Yes.
No, but tell me, I'm asking you.
It's to improve blood flow, to keep the path from the PDA open.
Just that pathway? Because see, like that, we can give that for other defects, right? Or conditions. Let's not say that. So let's open. So so when we use it, you think about this. So it helps us improve the blood flow, right? And it's not only for cardiology. So we need to improve blood flow to the uterus, to any organ. It's kind of like ibuprofen, right? So it's going to go ahead and improve the blood flow to the tissue. Right now, we're just talking about the congenital defects, but the medication itself, it can be given for multiple, what is it called? Conditions. So we're going to have a class next semester that is cardiac drugs, and we're going to learn what medications help us do what, right? For example, in this case. So when we give this medication, we are going to dilate the vessel. So what happens when you dilate the vessel? So the vessel is like this, right? So therefore the flow is like, so what happens if I do this? So vasodilator. So, but then I also have other medications that I don't want that. So I want to minimize. So vasoconstrictor. So I need to know what medications do what. And we're just talking about dilation. We also talk about, we can speed up the heart rate. We can slow down the heart rate. So, and those things, when we talk about that, those are going to be in your RCIS. Chronotropic medication. Chrono is what? Time?
Time, yeah.
So, right? So we're going to learn how to improve or how to increase the heart rate or decrease the heart rate. For example, when we're doing a valve replacement, aortic valve replacement, when we are delivering that valve, look at that image on the bottom. Can you show the valve, Nathan? The aortic valve?
I was gonna say, I got an
Oh,
X on your face. It's still
sorry.
following.
There you go. Just with your hand.
Yeah,
Oh, you're going to move it. Okay, got it.
it's still following the face.
Oh, got it. So when we see on that, can you show it, Rian?
Yeah.
The aortic valve
For the time,
on the bottom one.
is it here?
No, the valve. Oh my gosh. I only see 4 valves.
Oh, okay, these 4. Right?
So where is the valve? Aortic valve. Where's the aorta?
Right
And then follow down?
here.
Down.
Here.
The valve looks white, by the way. No, that's pulmonary. That's the aortic valve. No, that one. That's the aortic valve. We have 4 valves, and you see how that vision is a little bit different than we have seen before. We have just talked about it. It's like, okay, AV valves or semilunar valves. But now look at the position. They all look different. When you look at them on X-ray, they're going to look like that, right? The pulmonary valve is going to look like that, going north. The aortic valve is going to look like this when you see an X-ray. The mitral valve is going to look this. Look at the 2 valves. The tricuspid and the mitral valve are going to be like this. So you're going to see them like this, and like this. And you need to identify which one is which. And if you know the location, you know exactly which one it is. Because in an X-ray, we're not going to be able to see anything else but the wires. Yeah.
On an X-ray, are you able to see the amount of leaflets?
No. No. What do we see in an X-ray? What kind of material?
That's a great question.
Soft tissue? Not for sure. Right? So is the valve a soft tissue?
Is it soft?
So the valve, it's a soft tissue, so we cannot see it on an X-ray. But if we have a replacement of the valve, well, where I was going is when we are delivering that valve, we need to increase the heart rate to the max. So if we increase the rate, so we're inducing tachycardia, like big. So the heart is like this instead of da, 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 it's doing this. So we're kind of paralyzing so we can deliver that valve. So it's kind of, in a way, stopping the valve from doing this, this, this. So we increase the rate. So we're going to give medication to increase the rate. When we do, I think we're going to talk about other stuff at the end of these 2 weeks in Ms. Vasquez's lab. When we are going to get a wire inside of the coronary vessel that is what is the word I'm looking for? Lesion. Where the lesion is, we're going to get a camera through it. not a camera, a wire with a sensor that is going to tell us what is the percentage of this vessel open or closed, right? And it has to be, for a good vessel, over 0.8. And sometimes it's 0.79. So if it's 0.79, it's under 0.8. And that one is very little. That means we can do something about it. So for that wire to travel to the vessel, I need to slow down the heart rate because it's a foreign thing going through, and I needed to measure, have the ability to park and measure. Because if it's going normal rate, does that make sense? So that's how the medications, how we're going to be, this is how we are going to be using the medications. Vasoconstrictors, vasodilators, just to provide more irrigation to the tissue. Does that make sense? But you're going to have a full class on that. Good luck. I had a lot of medication on my test, a lot. But I did study a lot on the medication.
We have a pharmacology class.
Next semester. Cardiac drugs. And you have questions. I had like 3 or 4 problems. I had a lot of medication.
RCS.
And not everybody gets that. Like, I think Patrick got 1 math problem. 1, and probably the simplest one. Like, oh, lucky you. So it's, it's a pool. Okay, any other question?
Go over the differences between the ASDs, like explaining the ostium primum, ostium secundum. They form on the foramen above it, if it's the premium.
Foramen means opening.
Right, it's a malformation.
Yeah. Let me see if I have my PowerPoint, because I do have a PowerPoint for next semester. Let me see if I have it here. If not, let me see if I can find it on Google.
Another thing that is helpful is y'all figure out the video.
All late. I know.
Oh, man.
It's not all over, sorry.
Okay, I think this one could help us.
What was that, sorry?
The red mark represents the defect. All right, so let's talk about the first one here. Let me see. So the ostium primum is going to be in the base, thank you, the base of the atria. When we look at the base, look at what is happening here. So the base of the atria, when we look at it laterally, the ostium secundum, this is the one that is going to be the most common and is going to be right smack in the center and is greater than any of the others.
And that's where the foramen above it, the right?
Correct.
Okay. So ostium.
All right, so panel B is the ostium secundum, is formed by the poor growth of the septum secundum and excessive absorption, blah, blah, blah. Panel C is primum. Fossa ovalis is normal. Frontal view, the pyramid, let me see if I can get mine because I don't have structure on this. So let me capture this.
Ostium primum is where it just didn't link up correctly with the endocardial pressure. Right?
Yeah, hold on.
Sorry.
On your bed.
Yes. That's the ostium final bundle, and then.
Let's see this one.
Sinus venous defect. Yeah, a little bit.
Ah, I like this image. Copy image. Okay, how about this one? Does that one look better? Can we understand that one better? So this one, we can see them all together, and but this one doesn't have. So primum, which is the primum, is by the ventricle. Sinus defect, interior sinus venous defect. Okay, I think I like this one too. Okay. How about this one?
Yeah, people said had informed them about it. But that's specifically where it's asymptomatic. We don't see it until the blood.
So that's when it doesn't close.
Yeah. It's almost the same.
People have been doing
Yeah. It's almost the same thing as the osteum. Severe. Osteum is severe. That is the shunt.
And most common.
Right, the most common. And then the PFO is the one that doesn't show. That's the one that's like you're gonna find it there puberty or like your spines. People with that have fatigue. They have dyspnea upon exertion, and it can lead to shunting, which can lead to hypertension, pulmonary hypertension. That's like it's like a serious.
So why will we? Why? Okay. Yes.
So we would use prostaglandin E1 to keep that. You know, never mind. I can find my answer. I was gonna ask what do we do with patent ductus arteriosus, but I actually like paper on it, so I should know. But just ignore it. Because that's the opposite of prostaglandin.
So why do we have a PFO or as why is a PFO there?
It was in close after birth.
Huh? Yeah, but what is the function?
They can say bypass so it doesn't go to the lung.
Right? Because if it goes to the ventricle, it'll go to the lungs, and we're in water solution, right? So we don't have any air. So the PFO should close. Should, right? So is that flap, remember we talked about that flap that comes back, because it's like a one-way, it's only going that way, right? It's coming from mom, and then it goes that way. Comes from mom, that goes that way. So when the baby takes that breath, that pressure closes the flap, partially because it takes a few days or maybe weeks to entirely close that flap with the pressure. And then, but sometimes the PFO does not close. So there's that shunt.
You know why that happens? It just happens.
Like I said, some babies don't even cry when they are born. So they're just like, hi, I'm here. Like exploring the world. But then there's babies that like, you can tell like, and then they get purple before they get that first breath. You're like, come on. And then they take the breath and that's when we take. Remember, we take the measurements of the baby. We take it twice. We take it as they are born, and then a few minutes later to make sure this has happened.
That's why babies are always born like purple or like kind of like darker, I guess.
No.
Oh, just my baby.
No, babies are born pink, blue, yellow. As far as circulation, depending on what is happening, but you were what? A pink? Pink? Yeah, they're white.
Start, like,
Yeah, we do
warming them up and they can see their circulation kind of like
going. We stimulate. We try to stimulate it, but it's not true about that. Maybe in the past they will slap the babies. Yeah, but we tackle the bottom, huh?
They opened me up too soon. I was still in the sack.
Oh, really? Were you at term?
Yes. Yeah.
And you were born in the sack?
Yeah.
Were you a C-section or regular?
That was the section.
Oh.
They still stick it out,
Oh, yeah.
and they woke me up by accident in there. So
Oh.
I aspirated.
You breath. You took your breath.
That's all I have. Asthma.
Really?
Yeah.
Interesting. I have only one time have seen a baby born on the sack. Like vaginal delivery, regular vaginal delivery. She pulled it like that. And then baby was kind of like, what's going on with the light and everything, but in the back. And then pass. That was pretty cool. Yeah, we have a little tool. Huh? Yeah. We are animals. It's the same thing, except that we don't see it because the bag ruptures, typically as the contractions start. And C-sections, we always have to break the bag. Always, unless there's contractions prior, but we always have, we have a little tool, like, it's like when you're doing crochet, like a little,
Yeah, that's what I think they were like.
yeah, and it's a plastic one, it doesn't hurt the baby, so that, also, oh my gosh, so maybe you were very active in the,
Oh yeah, my mom told me that forever. Like she would get bruises. Her lower-
from you, like,
Yeah.
moving on. There you go. All right, so the location of the PFO will be central, and it's minimum. That is really not significant if the PFO stays unless it grows, and we need to close in on adults, not really on babies, PFOs.
How was that shown?
Huh?
How would that show?
As an ASD, it's just by the location.
No, like what would be like the symptoms of baby fatigue?
Same, yeah, same, because the pressure is gonna come, it's gonna be left to right. Do you think you can identify left to right shunts based on that?
Just like
How can we identify a shunt? Like if we have numbers, what kind of numbers do we need to identify a shunt? All right, so what is the regular saturation for a left atrium? Left atrium. No,
Right, I would think 97 and it goes down to 95 with left. Correct me if I'm
but we're talking left atrium.
Right?
That's right above the PCWP, well below it, but that's the highest because it's returning from the lungs.
Then?
97? I don't know.
Anybody else? Anybody else?
in the book it says 97.
Anybody else? 97? It'll be 100. It comes from the lungs, right? Between, and it's the lecture, right? But it's coming right from the lungs,
Okay.
right? So it could be, so if we have that saturation, okay, say 95 to 100. That will be, let's give it a range, right? And what is the normal saturation for the right atrium? 65? It's coming from the top, right? So what comes from the superior vena cava is less than what comes from the inferior vena cava because the brain spends more oxygen, right? So it returns less. So typically it's around 69, 70, what comes from the top, and then from the bottom around 75. And so sometimes we take samples from the top, samples from the bottom, and then a sample from the mixed venous, which will be the right atrium, right? So when it mixes, it's around 73, 74, 75 even, right? So 75 will be normal, right? What is the saturation for the right ventricle? Normal. 75. How about the left ventricle? Left ventricle. So it came from the left atrium and then left ventricle before it goes to the body. Around 100. So it mimics, right, the one on the top. So it really doesn't lose anything. So based on that, we should be able to identify if it decreases or increases. So if the right side increases, that means we have a shunt that is coming from the left. And if the shunt comes from the right, contaminating the oxygenated blood, what would happen to these numbers? Decrease. So it would be less than 97, 95, whatever the case might be. So that's how you identify right or left shunts. And we have formulas. We have formulas that we're going to talk about. They get complicated. Yes.
I'm confused. I know you're doing the visual cues.
Yeah.
I'm following, but then you lost me.
Mhm.
I see everybody else clicking, and I'm like, oh.
All right. So the right side is about 75.
Yes.
The left side is about 95. Normally, right? So if this side, which is 75, increases, why would it increase? Because it's coming left. The 100% is, or the left side, either right or, ventricle or atrium. So if the 100% oxygen comes to the 75, there will be an increase.
And that would indicate a right to left shunt?
Left to right. Because the left side, the left blood, the oxygenated blood, is moving through the hole into the right side. Now, on the other hand, we're just shunt, right? So on the other hand, if we have 100% 75 and then this one decreases, that means he received contaminated from the right, because the right is coming this way. And it does happen even though the pressures are different, it still happens. So based on that,
Due to like left heart failure. And at that point, because of the pressure is
it could also be the hypertrophy or
maybe a lot of things. Huh?
it's a lot of things, yeah. Or maybe, you know what, also a valve that is not closing properly, it doesn't create the pressure, so.
Also, like,
Or stenosis. Well, stenosis is actually more pressure on the right side, on the left side. Does that make sense?
Yes.
Maybe just like deoxygenated, oxygenated.
How they mix. So if the deoxygenated increases,
purple.
if the oxygenated decreases, that's it. Yeah, yes.
This may be such a stupid question, but so there would be, if it's a right to left shunt, they'd be cyanotic, but couldn't you also tell by their pulse ox?
Yes.
Just oxygen.
And just to be sure, that's what we're calling the step up, right?
Step up, yeah. Or step down.
Or step up, yeah.
But if we have pulse ox, but I mean, we cannot determine, the first thing that we do is the patient's oxygen drops.
Adjust their thing.
Check on the patient, right? First, make sure, because sometimes they're falling asleep.
Oh, and if they have like sleep.
Sleep apnea, forget it. They're gonna look, and their mask is like this, and you're like, oh, it's freaking out because your stats are dropping. But more likely, the first thing you do is check on your oxygen, as we know. ¿Qué más?
Are you going to be testing all the 6 pairs of brachial arteries? That was in the video. How like it all separates into our regular arteries.
No. Yeah, I think that's too much, and I don't think it's coming on the RCIS. It's just I think on the RCIS it talks about the development of the heart, per days or things like that.
So like when there's a heartbeat.
Yes. Mm-hmm. Yeah. And it's 1 or 2 questions about that, and it depending on the pool. But it's, huh?
You must know that, like, know which weeks formations are at. So,
For RCIS, yes. I mean, because we forget about that we have to study this.
Okay.
Yeah. Yeah, but for this quiz, you might need to know this stages. Mm-hmm. ¿Qué más?
can we go over that?
The stages? ¿Por qué no?
A straight heart to the.
¿Por qué no? ¿Por qué no?
So there's no labeling.
No.
Stable looping. Is that gonna be on the term? Like when the heart turns to the left side instead of the right?
I've never seen one.
Really? Right?
That's it. Remember, that's a because of the transition.
All right, so the formation, you might want to take just kind of like those notes, right? The formation of the cardiovascular system begins on the third week, right? So you might want to start that, third week. Third week starts the development of the cardiovascular system.
Is that also when the heart beats?
No. No, it's barely formatting. It's barely kind of getting those tissues. By the third week of gestation, the nutrient and gas exchanges need of rapidly growth embryo can not longer be met by diffusion alone. What is diffusion? We're getting from mom through their oxygenation. So we kind of, when the air goes from one area to the other, we're not really. The grade will be a different, yeah. But that's diffusion, right? It's not that it's going through a system or anything, it's just passing through the tissue. By day 22nd is when the endocardial tube forms, you know, when it gets like the little section. The primitive heart begins to beat around day 22 or 23rd, causing blood to circulate the beginning of the fourth week. So at this week, that's where we have the valves, right? The 1, 2, 3, 4, that the heart is going to start forming at day 22nd, right before it starts beating. Septation. What is the septation? When it separates, right? Because the septum is the one that divides right from the left. This one happens between the 4th and the 6th week. So that means it gets devolved first, like that we see here, you know, like all together. And then this is by week 3. And then between 4th and 6th, this is when the septum actually develops. So this is when the defects occur, right? When the septum develops properly or not. So we have septum primum. The roof of the atrium. Ostium primum, between the septum and the endocardial tissue. Ostium secundum. And it says that we have a figure 16.4. Septum secundum. This is when this is not a defect. So this is how it's like forming like from the top to the bottom, right?
But then if it goes wrong on that part, you can skip it.
Say we have the coding, right? It's like 1, 2, 3, 4, and then they coded like gets like a misinformation, and then it continues to go, but has that. So this is when the foramen ovale presents to leave room for that bypass of the lungs. Okay. I think that's all I need for dates. Let me see what else is on the dates. Atrial septal formation is at day 30, 33, 37, which is what we talk about week 4, between week 4 and 6. Why do we say 4 and 6? Because there is not really time to know when everything happens.
So all of this is just occurring around the same time.
So like I said, it's like a sequence, right? It's like the code is like go. So next tissue. So it's like a
I mean, like, so there's the straight heart tooth, and then it starts to twist, right? Then
uh-huh.
But that's at the 4 to 6 weeks, all of this is happening at the same time. Twist, and then the formation.
So obviously it happens first, right? The bulge first, and then the bulb, and then the septation. So it does have a sequence, but it could happen depending on production.
Yeah. So if one A to D, you get this A1, B, C.
Yeah, because it also depends on the coach, right? The DNA, how fast it's going, and there's no other issues. At the end of week 4, the ventricle begins to grow. So this is the septation of the atria happens first, and then the septation of the ventricle. I guess we can picture that sequence 1 through 5. I guess 1, 2, 3, 4. This remains open. Where's it here? So the interventricular foramen, we said it's a hole, right? So in the ventricle, I guess it takes longer, as I'm guessing, because imagine the atria is like ding, and then the ventricle is like 2 tings, a little bit larger. So it says here, it remains open till the end of the 7th week, but I'm not gonna ask that. I want to know the first few weeks, let's say all the way to septation. And then after this, week 5, arterial pulmonary septum. And then I want to know after this, I want to know so the valves form in week 5. 5, 6, and 7, the valves. And then the fetal circulation, that's so the blood bypasses the liver and the lungs during fetal life. So when we cut the umbilical cord, it does have the 3 vessels. So we have to make sure they are actually healthy when we cut. The first thing that we do is check and make sure the irrigation was present. So we're gonna bypass from the aorta, going through the internal iliacs to feed, and that kind of makes sense because a lot of the pregnant women start developing edema because it's on the leg. Oh, that makes sense now. Because we have a lot of there's a lot of things happening. And then the bypass of the liver is going to be through the vena cava. So I did not know that the bypass was also the liver. Yes.
But when they say that it's more beneficial, I think like delay the clamping available for because
Okay, so if the baby's already breathing on its own, why would we need? There's a lot of debate, and I went in through so many deliveries, and they're still always like, oh, leave it. There's not even pulsation anymore. Now, another thing is, as soon as the baby is born, the mom releases a chemical to separate the placenta from the uterus. Immediately. So that's why baby is born and then the placenta is born. So it's only as good as.
I went through that class. I was like, I was not ready. She was like, no, it's not. You're not done after the baby. I'm like, what do you mean? She was like, yeah, I had like the afterbirth. I'm like,
Was that a doula or?
no, well, it was my anatomy and physiology teacher. She was very well educated. She was a truly amazing woman. I love the way that she taught her class. But she did bring in a doula, and she brought like someone in, like when we were going through the.
But it's doula related.
Yeah.
We don't like the doulas in the work. I mean, they have all this holistic vision, and if they request that we delay the cord, we do. You know, it does not benefit in any way, shape, or form because the baby's already breathing on its own.
Yeah, I'm asking because I honestly don't remember entirely my delivery. I didn't see my baby.
Mm-hmm.
I remember someone mentioning like, oh, like delay the clamping, like if you can. My husband was the one kind of like talking with the doctor because I don't remember any of that. I just remember her after, hey, can we take the baby? They took the baby and she was like, okay, we're gonna do your placenta. And her pushing down my stomach. So I don't really know.
The placenta comes right away. You know, the pitocin releases, as soon as the baby's born, the pitocin comes through the system and then this separates the placenta from it. So if anything, it's toxic. You know, it doesn't have any more oxygen. While the placenta is still plugged into the uterus, okay, I guess, but it's just, you know, the baby's doing its own circulation already. So I had a lot of the doctors saying that it was useless. And we don't have doulas, we have midwives. Some of the midwives will go just because the patient prefers to have a more holistic type of delivery, but it's not really based on science, oxygenation or anything like that.
So what do they believe?
What?
Like, where did the dualists believe that or they would be delayed?
Like I've heard, because they asked me, like, do you want? I was like, what am I gonna do with it? But they asked me when I gave birth to my son, they're like,
You wanted your
"Do wanna delay
placenta?"
the cord?
Oh.
I'm like,
For what?
why? And they're like, well, nutrients and stuff. I'm like, but he's already out.
Mhm.
What nutrients? And they're like, well, they were like, some people believe that there's like nutrients stored in the placenta that your baby can still get. And
But
I'm
the
like,
baby's
well,
been feeding from 9 months already.
yeah, and I was like,
It's like breastfeeding. You know, up until some time, it's not even beneficial anymore.
yeah, and I was like, well, that's the point of breastfeeding him now because the placenta doesn't have to feed anymore. Like that's the point of me. So
It's really more holistic and the choice than.
they put my placenta and they're like, well, do you want it?
Do you want it? People take it.
Yeah,
People
they're
take
like,
it.
Another thing is also does it really benefit, like if I were to eat it, right? People encapsulate it. and
Yeah.
eat it, And I was like, I don't want it because when I was doing more research, they were saying that it also is or like other people's.
Because it's toxic.
Yeah.
You know, it has their tail and everything, but it also collects all the toxicity from the environment. So a lot of people keep it. A lot of people.
And the doctor was like, do you want to see it? And I was like,
No.
And like in the pictures, my face was like,
Ugh, gross.
And my husband, he was in EMT school at the time. He was like, yeah. I was all like,
It's cool to see. It's cool to see.
I got to, like, I mean, because I grew it, so I was like, I want to see what I did. So
Yeah.
I was able to pick it up, and the nurses are like, "Are you a nurse?" I'm like, "No, I want to see what I grew." Like, I
Yeah, the little bag.
I grew a whole organ. Yeah, so I picked it up. It was heavy.
It's heavy. Yeah.
Yeah, it was really gross.
I just
But
remember
so
being
detailed.
like, okay, we're gonna push in your stomach down. I felt that come out rather than like the baby.
I was passed
It
out.
was like she just pressed on my stomach and it was just like,
Yeah. It's a bluff because it's heavy.
yeah.
So it comes. So we press on the fundus, a little massage, and then somebody's pulling. So then it comes out. The guys, very interesting. Huh?
Yes, I was given epidural, but I passed out because I was bleeding out, so I couldn't see them. I couldn't hear them. I told my nurse I couldn't make
You were bleeding
Yes.
because that placenta came out too fast, or what?
So I was anemic when I went in and they checked my blood levels and they're like, oh, you're good because they gave me iron pills. But I went in and then I had my baby. He was fine. I had no pain. Everything was good. Epidural was good. And then I was talking to my nurse and I told her that
I don't feel
I
good.
couldn't see her.
Yeah.
And
Yeah.
I was getting hot.
Yeah.
And she was like, what do you mean? And I was like, I don't feel good.
You're like,
I can't
bye.
hold the baby.
Yeah.
Yeah, so I gave the baby to my husband, and then they lifted the sheets. And now
Were you in labor for a long time?
Not long. I can't remember because I went
3 hours,
at
10
11,
hours, 12 hours?
and they told me I was at 2 centimeters.
Mm-hmm.
I went back at 4:30, almost 5, and they're like, "You're at 5." They took me to my room 30 minutes later. I was at 7, but then I didn't give birth till 2. Yeah.
So 14 hours in labor. So think about it. The contraction of the uterus is like try.
Yeah.
Try.
Like
So
2-minute-long contraction.
it's always very risky when we have those patients that are not delivering soon because we know it's going to be a bleed because the muscle keeps working. So it's like I'm exhausted, like I gave it all and then that's the bleeding.
Yeah, and it was like.
So the ones who have not had a baby, listen.
Wild surgery. They took my son right away because I was like, I think it was like a total of 16 hours. I was only pushing for 20 minutes.
Oh.
It was 16 hours.
Mm-hmm.
So when I delivered, he already had a fever.
Oh.
And they were like,
It was already toxic, yeah. And they wanted to delay and on top of everything else.
I just don't.
Oh,
I remember
no.
when he came out, they're like, can we take the baby? I was like, yeah, that's fine. Because they tried to give him to me, but like I had him. And I was like, can somebody wipe my hand? 'Cause
Oh, yeah, yeah. All the cheese.
Can somebody wipe my hand? You know? And I just remember telling my husband, like, don't leave me. Like,
Yeah.
the doctors had the baby. But they were, apparently, yeah, they were like, they were for like a really long time. Like, that's not.
And you were bleeding too?
I
Not
think
really?
She said that I didn't bleed too much. I didn't like tear as much, but they were
Yeah,
concerned
the
because of
pitocin.
how long I
Yeah.
was.
Yeah, there's always that concern.
And I was ready to push. I think at like
Oh
5
boy.
or 7.
Oh, yeah.
She told me to wait to get the epidural as long as I can, but I felt everything.
Yeah.
I felt her stitching me up. Like I felt everything.
But no with pain.
Yeah, it
It's
was like-
diffused. I mean, you still feel
Yeah, I
it.
still feel it, but it wasn't
Yeah.
like the way that they had explained it. And they were like, well, we can reposition, and we can do the epidural again.
Yeah.
And I was like, dude, you gotta do, because I remember telling them, I was like, take me for a C-section. Like I'm done. I can't.
Oh my gosh, no.
She was like, you're at risk for rupturing your cervix if you start pushing. And I was
Yeah.
like, do like get the doctor.
Something.
Like, I'm ready to deliver the baby. So then I just remember the charge nurse coming in and she's like, we're doing this. Like, let's do it.
Let's go.
And then I remember it hurting. And she was like,
Yeah. But it's nothing to the pain that it will really be.
yeah, no, I think I
mean, you still feel.
I didn't knowing I was gonna get an epidural, but still feeling everything. I was like, this was not fun. And then it freaked me out to when like they finally propped my legs up and I couldn't feel my legs
Mm.
as much. Like,
They're super
I feel
heavy,
it
yeah.
kind of, like, this-
You can move them, yeah. Like
yeah, like it freaked me out. I was like, I don't know what
you get scared. All right, those are the stories for labor and delivery.
It's
So when the babies are, did the baby cry?
he did eventually. Yeah.
Or eventually, it took him a little while. Yours? Oh, you don't remember?
No, well, because I didn't know that till after the game.
Oh.
So he cried, and then once they wrapped him up, he stopped.
Oh.
Yeah.
Because when we put their blanket, they just want to be like this because
Yeah.
they're coming from this environment to this environment.
Yeah.
And they're like, what is happening? And then they're scared. They're like, what is this? They're not used to be like this. So they're all shaking. And then when we wrap them, they come down.
Stopped
Yeah.
crying right away. Once they put him in, he didn't care.
So at that time, the circulation changed, right? So that's when we take the flap of the PFO. And then the route starts taking to the lungs and to the liver that I didn't know. So the circulation is going to now switch to the lungs.
So the liver is also part of.
Well, the liver is a bypass. So the liver is bypassed. So it's not getting blood from the baby. Yeah. Interesting. 3 territories. And then we call him the tree of life because he does look like a tree. Okay, so you need to read this, the transitional circulation, because this is what happens when the baby is born and immediately right after birth. The umbilical cord starts drying like right away. We clamp and there's no more nothing through that umbilical cord. Starts drying, period. So look at this. As the umbilical cord is clamped, the low-resistant placental flow is removed from the arterial system, resulting in an increase in systemic vascular resistance. Simultaneously, pulmonary vascular resistance falls for two reasons. One, the mechanical infraction of the lungs. Huh?
They would get rid of valves.
Inflation of the lungs. Okay. The mechanical inflation of the lungs after birth stretches the lungs tissue, causing pulmonary artery expansion and the wall thinning. And the vasodilation of the pulmonary vascular occurs in response to the rise of blood. So if the lungs expand and receive that, so that creates that's why the resistance becomes low, because there's more space to send, right? So where it was like just this, and then I create the reroute, and then the resistance goes low. So that's probably something I want you to know. The vasodilation of pulmonary vascular occurs in response to the rise of blood oxygen tension, restoration of the lungs. All right, so if I ask you what happens in this after the baby is born, the reduction of the pulmonary resistance and the rise in pulmonary blood flow. Make sense?
Can you repeat that one down there?
The pulmonary blood flow increases and the pulmonary resistance reduces. Pulmonary resistance flows and the blood increases. That makes sense, right? Because now we are covering that area. I think that's all I'm gonna need for the for this chapter. Well, from the development.
So do you want us to know like each week what is happening?
Roughly. I mean, not a whole paragraph, but like what happens at week 3 starts, right? And then at week 4.
The major landmarks.
Yeah, 5, 6. Yeah, exactly. Just landmark. What happens at this particular week? So what happens between 4 and 6?
That's where
The septation, right?
Septation.
So the twist first, and then the
Oh.
Septation
Oh, you
of
have that,
the
yeah,
atrium
yeah,
and ventricle. The atrium happens
first, and then the ventricle. Okay. Well, that's what I have.
Are you gonna test us on Eisenmenger syndrome?
On what?
Right.
What was the other infection? But it was like
Epstein.
it was.
Let's see if it's here.
It's all the just
It's called Epstein.
Epstein
407.
407.
The Eisenmenger, the left right left and right. Right? No, I thought that was the much. No, yeah, I thought that was.
There's that,
I think it's here.
right?
there it is.
Oh, it was there?
Well, the one with,
I don't know.
right? Maybe not that one, because I don't know if that's
That's the ice.
German names, yes. Don't get like burgers or something after this, because I don't know about y'all, but I'm like,
Hungary.
in Mexico has one on his arm, and it's the duck bill and part of the stem.
So on this syndrome, the right atrium looks like it's bigger than the ventricle, but it's really the displacement of the valve. The valve is not working, so the valve is dragging, and looks like the right atrium is larger, and the right ventricle is smaller, but it's just the valve unable.
Well, because we thought it was a P,
Oh,
but the other thing, they probably changed it on.
Epstein. Me?
No, they probably changed that.
Oh.
Is it syndrome?
Oh, instead of Epstein?
Yeah.
It's not.
Okay, yeah.
It's a weird, it's a,
like.
So does that make sense in there? Like, where's my handy hand? Looks like the atria is large, but it's not really larger. It's the valve that is kind of like sagging. Mm-hmm.
It'll be kind of like my Coca-Cola.
No, it doesn't have any support, any of the structures to support the valve.
Oh, so there's like no tendon coordinator or anything.
Or like capillary.
Look at this one. So it drags.
Huh.
So what week will that be?
What?
This problem? What do you think? What week? Which week is this developing?
6.
Because we talk about the valves. Weeks. When is the valve? The valves.
Oh, that's week 7.
Hmm.
That's the late action.
Yeah.
So even the RV is still the same, it's just the valve itself?
Yeah. Look, it's prolapsing, and because of this, there is. Look at the increase of the size on the right atrium, but that's later when it's receiving this blood and it doesn't know what to do with it. It also increases. Let's see here.
So that leads like a massive pressure, or
Look at-
just to a low pressure within the RA and a really high pressure in the RV.
But then, how do we have pressure? We don't have valve,
Not sure.
right? Let's see.
So would this heart be functioning like a hypoplastic right heart syndrome? Like,
This is different because in the hypoplastic, the valve is fine, and this one, the valve, which
What do you mean?
So now you just draw just like a funnel. So it'd be like
Yeah.
one large right atrium.
correct looks like it's a large right atrium,
Yeah, but like the whole right side.
right? Because of the valve.
Will it only happen on the right side?
Yes. Trying to see if there's anything like image.
Is there a condition like that for the left side, for the mitral valves?
Now, when the mitral valves are not working, either stenotic or regurgitating, of course, there's going to be increased pressures on depending on the valve, on the, when we do, remember that I said that sometimes we're going to have a right and the left heart at the same time studies? That's when we're trying to study the valve. So if we see that there is a discrepancy between, depending on which valve we're talking about, if we have a difference on the pressures, because we know they have to equalize either systolic or diastolic, that's when we're going to know if they're regurgitating, weak valve, or stenotic, like stiff, depending on the pressures. So that's how everything kind of starts getting together. But that will be just valve. And if we have regurgitating valve, which is weak, it's not closing. So it will, not exactly like this, but it will reflect, so the ventricle is unable to push out because the valve is kind of like not helping. So this is going to increase the volume. It's going to become like a lazy left ventricle. And when we have a stenotic valve that is not closing pressure, so there's always pressure leaving through there. So this ventricle is working and working and working against this. Welcome to cardiology. And it's just the heart. There's.
What was it? Is all the pulmonary circulation. Yeah.
And everything that goes with it, right? Because you go legs, rotted, brain.
I'd rather learn about the chemistry module. Or...
Uh-huh. Me? Or we're gonna, no, not chemistry.
All right, cool.
Not chemistry.
I would say because
No, like the only chemistry-ish that we're gonna know is the medication. How do we affect that? That's it.
I go.
But that's about it. the agonist, antagonist, but that will be more for reactive, like increasing the pressure of the heart or,
Yeah, the pharmacology.
yeah. But that's it. That's the more chemistry that we're going to go. Bueno. All right. Vamos. Sí.
Yeah, those
It is what it is. I don't think I have very